her off oxygen because I wanted to see how she was doing without it. After a couple of minutes, the minimum she went down to was about 94. Her heart rate was about 100, irregular. She did have a history of AFib. But the thing that I noticed most was her kind of tachypnea. She had some nausea and a couple episodes of vomiting, perhaps, but didn't really bring up much. No diarrhea, no chest pain. So this was her initial EKG that I got. I want to pass it around. I have a couple of them, actually. They look pretty similar. Here's another one.
You want to post it for everybody?
It's the names at the top, so be careful.
So we'll show it here, and then I'll put it up on the... Okay, you can see it there. And I'll put it up so while we talk about it.
And here's an old EKG of hers also.
Let's get the name at the top.
Alright, this is an old EKG. And we'll put it in there so you can see it a little bit better. See, hold on.
So what happened?
So on this lady, so I see this new EKG, which looks like, I don't remember it all offhand, but it basically looked to me that there was a little bit of ST elevation in AVR, maybe about a millimeter or so, a little bit of ST elevation in V1, ST depressions in 1 AVL, and also a little bit of elevation in 3 and possibly AVF. So I was definitely concerned about this woman, especially compared to her old EKG. At this point, I wasn't really convinced that this was a STEMI, even though given the ST elevations and depressions, because she really wasn't having chest pain. And now, granted, elderly people, they talk about the classic elderly woman with diabetes, that it's not presenting the same, but to really have no other symptoms besides shortness of breath to me kind of seemed less likely that it was a STEMI. Although I was concerned about right-sided stuff as well, just because of the elevations in AVR and V1. So I got right-sided leads over here, which are marked, which showed also a little bit of elevation in V5 and 6, about 0.5 millimeter. But again, given the fact that she didn't have any chest pain, I didn't really want to call this a STEMI at this point. I called the interventionalist just to kind of run it by him.
We'll talk about right-sided leads for a second. So people think you have to get full right-sided leads for a 12-lead EKG, and that's not true. The only thing you really need to get is V4, right? And V4, so it's V4R we say, so V4 meaning right-sided leads. And the rest are just not very sensitive. And there's multiple findings you can have in V4R, from ST segment elevation, depression, T-wave inversion, ST segment depression, to indicate that it might be RV extension. But I'm a big believer that if you're in an ambulance, there's very little indication to ever get right-sided leads. It just doesn't matter. If you're among your patient's hypotensive, no matter what V4R shows, assume they're saying to the inferior wall, don't waste any more time on the scene. And if they're not hypotensive and your EKG shows something in V4R, it might mean they're extending, it might mean not, but you're still going to go to the cath lab if they're having an acute STEMI. So the utility of it is more academic than really beneficial clinically.
Yeah. So I did that. It really didn't change much kind of everything at this point. But given her tachypnea, and that ST elevation in AVR could be a whole bunch of different things. This is a narrow complex ST elevation in AVR, so you can definitely get it with TCAs and other stuff, but that I would expect to see wide complex. I felt like it was either this woman was, based on this, was probably either having a PE or an MI, because of there was like an axis change on the EKG, the elevations in AVR, depressions in 1, and
the PE
AVL.
Because why? Because she had right axis deviation
and these ST depressions without chest pain, all she's complaining of is shortness of breath. So it kind of put the whole thing together for me. So then I decided to do a sono of her heart to kind of see what was going on, and on the apical view, I saw a really big right ventricle. So it was basically kind of clinched a diagnosis for me that I really felt like she was having a PE. Now, she also has CKD, so, there's the whole, I want to get a CTPE. So I put her in for that, and I want to get it immediately because I'm concerned about this woman. I just don't like really the way she looks and the way she's breathing, even though at this point all of her vitals are actually okay, but she just didn't look good to me. So I put her in for the CT. She gets wheeled over to radiology. Sure enough, radiology calls back to say her creatinine's 1.5. We can't do a CT on her. I'm like, well, I need we need to do the CT. You can call the radiologist. So I call the radiologist. I tell him a story. He's like, well, clinically, this isn't a PE because she doesn't have lower extremity edema, and she probably doesn't have a DVT. I'm like, I mean, there are PEs without DVTs, but everything, I got ST elevation,
like
AVR.
many clots come from pelvis, right?
Yeah. And I see ST elevation and AVR combined with the huge right ventricle on an ultrasound. I mean, I don't know what else is going to be causing this besides a PE. So he's, after a whole bunch of back and forth, he agrees that if I, discuss all the risks with the patient and her family and have them sign all the paperwork, that they're going to do it. So I talked to the family, and he actually suggests I do a VQ scan on this person, which would involve calling in the tech from home and hours upon hours of delaying the diagnosis, and I just thought that was not adequate for this patient. So we ended up getting the CTPE, which showed that she had pulmonary embolisms in both right and left upper lobes, left lingula, right middle lobe, I believe, and right lower lobe, so extensive. Her pressures dropped into the 80s or so, and then her troponin came back at 1 point something. So at this point, I felt like she was decompensating more, and I wanted to give her TPA. So, we asked the nurse to get TPA at the bedside, moved her to the more acute area of the ER, and actually I ended up giving her TPA 100 milligrams over 2 hours, watching her pretty closely, and within about an hour and a half or 2 hours, she actually started, her color got a lot better, she was looking a lot better, she got admitted to the MICU. I also started her on Levofed because even while the TPA was running, her pressures kind of stayed in the low 90s, high 80s or so, but I just didn't want her to decompensate any further, so we gave her Levofed, and I checked up on the chart a day ago, and she was actually out of the ICU and breathing a lot better right now. They're getting her off oxygen now. So it's a good case. I mean, I think, these are subtle EKG findings on these EKGs that I think can often quickly be overlooked as a regular EKG. I mean, when we get thrown 1,000 EKGs in our faces and you're looking at them very quickly, there's nothing, if you look at this really quickly, I mean, there are the depressions, but the elevations I think could easily be overlooked. And like some of my teachers always said, it's important to stop and take a minute to look at that EKG as opposed to just looking at it and then while you're still talking or hearing another case, because in this case this probably didn't make a difference. And if this woman sat there for another couple of hours in the back of the ER without anyone really going to see her, she would have died.
It's a great case. You saved her life. She didn't have an S1Q3T3, did she?
So actually she did on that EKG.
So we all talk about this S1Q3T3
Yeah.
as a classic finding for PE, when in fact most people with PEs don't have it.
Yeah.
Right? But if you see it on the EKG in S1Q3T3, you should, I guess, it should still be in your differential, like it would based upon the history.
Yeah.
But it was more the right axis deviation with some of these findings.
Yeah.
And the choke was probably from more PE, right?
Yeah.
And you saved her life. I mean, when did she become hypotensive? After the CT?
Yeah, I think she was always in the low hundreds or so, and then when she dipped down to 90s, it was later on. I mean, before she got to TPA, she was in the ER for about 2 hours or so. So it was after the CT that she became hypotensive. She had one hypotensive reading earlier, but then it came back up, possibly related to the fluids that I gave her. Although I was reading about this stuff, and it may not be that fluids are actually so helpful in PE, and we could definitely overload these people as well. So it said to kind of start giving vasopressors earlier as opposed to just taking them up with a lot of fluids, and that's why I decided to give that as well. But yeah, and then I've been carrying around these EKGs with me, showing to paramedics that I've been seeing on the street and stuff to kind of just show them that, and then one of the paramedics said to me, "We never see PEs." Well, you probably do see PEs, you just don't know that it's a PE at the time.
Tons of PEs pre-hospital.
Right, because we're not diagnosing them pre-hospitally, but unless you find out down the line that it was a PE. But this again, looking at this EKG really quickly, you could say, well, there's nothing really acute going on, and maybe, and I really do believe that the pre-hospital care determines the hospital care, and when paramedics come in worried, and that gets put in the chart, it affects the downstream. It affects the downstream effects of what's going on with the doctors and the nurses and a lot of this stuff. And early recognition of this, I think, is very.
So you would not have TPA'd her if she hadn't dropped her blood pressure, right?
If she hadn't dropped her blood pressure, I probably wouldn't have TPA'd her.
You probably just would have anticoagulated her.
I just would have anticoagulated her. Yeah.
And did they do an official? I'm sure they did an official echo later, after yours. And I'm just wondering if her RV was still dilated.
Yeah, I didn't. I could take a look and see. I'm sure they did, but I think it takes some time for the RV to go down,
Right,
but it
that's
doesn't
what
go
I
down
think.
immediately. So even I did an echo actually about halfway through the TPA just to show some of the other doctors there because they weren't so familiar with how to do echoes, and I wanted them to see it as well. So I showed them, and it was still dilated at least halfway through the TPA being given.
You know,
But it definitely takes time to go
We
down.
always talk about, we always pimp people. What's your differential for acute left-sided heart failure? What's your differential for acute
Yeah.
right-sided heart failure? And of course, your differential for acute right-sided heart failure is a PE. But yet, I never see too many people with acute right-sided heart failure at all, right?
Yeah.
I just, I don't, or like acute edema, or as being caused by a PE. But we
Yeah.
always talk about it in the differential. I mean, I guess she sort of had acute right-sided heart failure, but she was short of breath. Well, the shortness of breath was from the PE itself.
Yeah. But I think in these cases, like this undifferentiated shortness of breath stuff, I think this is really kind of where the ultrasound can potentially make a difference in what's going on with
So,
the
and help me remember the latest way to dose TPA for PEs. So you gave 100 milligrams over 1 hour
Over
with no bolus?
2 hours with no bolus. I actually had given her 5,000 heparin bolus just based on my suspicion before, either right before or right around the time she was going to CAT scan, because to me, I mean, I couldn't really explain the EKG findings combined with the ultrasound by anything else besides a PE at this point. So, I didn't feel like I needed to TPA her at that time. She didn't look too bad, but
Just to play Monday morning quarterback, why wouldn't you give Lovenox where you can get them therapeutic like in 30 minutes to 2 hours,
yeah.
as opposed to heparin where you can check a PDT in 6 hours and it often takes us 10 hours to get somebody therapeutic.
Right. So with her, I was concerned about her decompensating. Oh, a couple of things. She has underlying renal disease, so I needed to see what her GFR was at that point, or creatinine clearance,
Because you have
to
to
see if
change
I can
those
give her
Lovenox.
Lovenox. The other thing was, if we wanted to do, intravascular, I don't know if I wasn't sure. I don't work at that hospital too much, so I wasn't sure exactly what the capabilities are. If she needs to be transferred to somewhere else to get a thrombectomy or something, if the Lovenox would kind of interfere with them being able to do that, if she would decompensate. So I thought that at that point heparin was just a kind of safer bet.
Or if there's any bleeding diathesis. So if they run the risk
Yeah.
of bleeding, you certainly heparin's the way to go, because you can just shut off
Yeah.
the heparin where you can just shut off the
But I would much
Lovenox.
prefer to give Lovenox, absolutely, rather than heparin. I hate checking the PTTs every 4
Plus
hours.
the
and you-
therapeutic quicker.
Yeah.
I mean, it's a factor, if I remember right, it's a factor 10A, right? You check for Lovenox. But the problem is we typically don't check 10As in patients. And we don't know what a normal 10A is. It's probably somewhere between 1 to 3. The literature is very conflicting what a therapeutic 10A level is.
Yeah. So it was
That's
a good case. Yeah.
Anybody else have an interesting case? Pre-hospitally or...
Just to add on to that a little bit, I think that would also be an easy one to, like, all right, her rate was 100 in AFib. Let's say, plus or minus, she told you she had the history of AFib, and maybe the rate was 115 or 120. And if you tried to, like, cardizem her or rate control her, you probably would have seriously harmed her. So getting the whole story in the picture.
Right, because people you vasodilate or preload reduce, if they have an acute enlarged right ventricle or even chronically like cor pulmonale, they're the ones who are most at risk of becoming hypotensive. Right? You give nitro to somebody, how do you know if your nitro is going to make somebody hypotensive? If they have COPD or cor pulmonale, obstructive sleep apnea, they're at higher risk of getting hypotensive. And if you've misjudged them to really be a right-sided heart failure versus left-sided. I mean, I remember the patient years ago who had a PE, was taking her to CAT scan because I suspected it. She had recent surgery and she bottomed out on me and her blood pressure went way down. And I gave TPA, but I didn't do it right away. And I said, let's just bring her to CAT scan because CAT scan was calling. And as they're calling, she had been stable, and then she dropped her pressure to like 80. We gave her some fluids. She went back up pretty quickly, and I didn't TPA her until she came back from CAT scan. She came back, and then she had persistent hypertension. And just by TPAing her, I never got her back. And I always think if I had done a TPA when she just had her first drop in blood pressure, would she be alive? And that's a hard question.
I think these are always tough, and I think we get scared when we're doing interventions that we don't normally do, and we're hesitant to give TPA because we don't see it given so often. I mean, we see it for strokes and stuff here and there, but for PEs, how often are we giving TPA? I mean, are we used to the dosing? Are we used to all this stuff? And it's we can easily bias ourselves and say, oh, this isn't that because I don't want to do the intervention. I think it's important to try and really be honest with ourselves and say, you know, and even if it is the right intervention, while it may be scary to do because we haven't done it at some point, you know, I think the hardest thing is to just pull the trigger, and we got to do it sometimes.
And just to be clear, we see lots of PEs day and night. We just don't see that many hemodynamically unstable. Does anybody else have experience with TPAing a PE?
I've seen it twice, and both times they died, unfortunately.
Yeah.
When they're.
I think because that's when we start to grab for it, and then by the time it comes up, and like, oh man, they're really sick. We should just do this. It's just like I think it's a delay.
If you're at a site that has a, you know, they're very comfortable with PEs surgically, because you can get the embolectomy team involved early on, and I feel like outcomes after they do a full embolectomy are a lot better. And a lot of the times, what they're saying is just give TPA, even if they're going to the OR. As kind of a bridge, but they find it just takes longer to evacuate the clot once they get inside because the clot's more broken up. But they can still do it. They just think it reduces the burden and they're more likely to survive. I don't think there's any robust literature backing it up though.
This scenario, this is showered PEs kind of everywhere versus a saddle embolus is what we classically would kind of say this is what really would drive us to do an embolectomy.
Right. I mean, the question is, in your patient, I mean, you already had the CAT scan results. What if she had persistent hypotension despite levofed before your CAT scan? I mean, that's a hard question. Would you have TPA'd her then? And I think whatever answer you give, like I don't know this wrong.
You know, I think, I mean, I think for me the diagnosis is kind of made with the ultrasound findings plus
a big RV
plus this. So I would have. You know, I actually asked the nurse, can we get the TPA at the bedside? Because you know, when she came back from CAT scan, or someone laid her down at some point, and I walked over there and I'm just like, damn it. Like,
So
I thought
good.
she was going to die at that point when someone just laid her down. And I'm like, this woman cannot be laid down anymore.
So you think that if the RV wasn't big, you probably wouldn't have given the TPA?
If the RV was not big,
And you
I
did have the
probably
CAT scan
would not
done.
have at that
Right.
point. Because
Everybody
I don't know,
agree with
maybe
that?
it was a dissection, maybe it's an
Right,
MI.
maybe it's a
you know.
dissection.
I mean, granted, if it's a MI, a TPA would be just fine, but
On the other hand, maybe she had a big RV due to a million different reasons,
Right,
and she was dissecting.
absolutely. I mean, I definitely did think of dissection in the back of my mind, you know, because I did push heparin before I had the diagnosis, and I did think about it, but, you know, just based on her symptoms, you know, I checked all of her pulses everywhere, and her symptomatology just did not seem to me to fit with dissection so much, although dissections can really be anything.
I think if you're going to rely on the ultrasound, you have to take the whole clinical picture in to check, because if you're looking at the ultrasound and you see a big right ventricle, you have to look at the size of the muscle. If the muscle's thin and it has not had time to beef up, then that's an acute change, and you have a giant right ventricle. But some patients who are having PEs are chronic.
So say that again, because what you're saying is really important. That, you know, people say, because, you know, we echo people all the time, and we can tell they're EF, and sometimes we can tell warm motion abnormality if it's really bad. But the question for us is this acute or is this chronic? Because we have a lot of people who have a lot of comorbidity. So sometimes looking at the thickness of the wall muscle helps us.
Right. So in acute right ventricular strain, so you have a massive clot, you have something acutely that's increasing your pressures inside of the lungs. The wall's going to dilate, but the wall will be thin because it has not had time to beef up, to have a lot of time to beef up those muscles against a big pressure. People who are chronically throwing clots, people who've had PEs previously, they have increased pulmonary pressures to begin with. So if you look at them, they can chronically have a dilated right ventricle, and you can tell that usually by the thickness of the wall. When you look at their heart, the wall looks basically the same size, if not bigger sometimes, in the left ventricle.
Right. The problem is we see people who have thickened walls and come with acute events. Right.
So I think if you have unstable vital signs and you have, from what you can tell, a dilated ventricle, whether or not it's acute or not, you know, you should really consider TPA. I think that's what I'm most likely going to consider giving.
Right.
To Drew's point, what you were mentioning was like, let the patient was tachycardic, and let's say you had to give cardizem. This is a mistake that we make very commonly, you know, and even in the field, but also as practitioners, that we tend to treat tachycardia and we want to like bring this heart rate down, but we have to realize it's a compensatory mechanism. And this is a compensatory mechanism that, you know, if we try to correct it, you can actually, you know, do patient more harm.
Yeah.
And we see this a lot in CHF. Like you see patients who they're saying they're in, you know, AFib RVR, they're tachycardic, they're tachypnic, and they've got rails all the way up, and they want to like give cardizem. And I mean, but you know, sometimes you see this because you're just thinking about this heart rate that you got to manage.
Right.
But at the end of the day, what you got to do is treat the underlying cause. and that will actually drive the heart
But
rate
let's
down.
pin you down. So the paramedic unit
Sure.
calls you. They tell you the guy's lungs are clear, SAT's okay. He's an AFib at 140, and they want to give cortisone. You know that maybe it's a compensatory mechanism for something else. You're not sure if he's febrile or not, but somebody tells you he doesn't feel warm. And you know there's a phenomenon of rate-related ischemia. We can become ischemic because the heart rate's fast. Do you give the order for cortisone or metoprolol or not?
So the question is, what's the underlying cause? Like, what is their presentation? What is the chief chief
But
complaint?
we know that the most common cause of AFib is chronic hypertension,
Right.
causing left atrium to slowly enlarge over time.
Sure. I mean, if it's at onset of like maybe some symptomatology or maybe like some shortness of breath, maybe palpitation, sure, I think it's reasonable to do. They're symptomatic. I don't think it's unreasonable. But if you get someone in the setting of where you're concerned of like this patient could possibly have a PE, or this patient does look like decompensated heart failure, then in that scenario I would say I take a step back and say, okay, maybe not.
Right. But the incidence of people presenting with PEs with new onset AFib
Right.
is
Probably
very
not
rare.
Very rare.
Right.
You're going to be tachycardic more than anything.
Right.
But we do commonly see this in CHF.
Right. So what if I made the guy's heart rate AFib at 120?
Yeah, I wouldn't touch it.
Yeah. So your cutoff is somewhere between 120 and 140.
Yeah, I would say probably like anything over 140, 150, I would probably start treating. Otherwise, I'd leave it alone.
Right.
I mean, I feel like, with people who have underlying AFib with RVR is equivalent to sinus tach in someone who doesn't have AFib.
Right.
Sure.
So,
Agreed.
I think when we think about it that way, and if we're going to slow down, are we going to slow down all of our sinus tachs? No, right? So why, if someone has AFib, are we going to slow down, our AFibs with RVR? And I think maybe sometimes we will, but a lot of times I think we just kind of need to look for the cause of what's going on. Is it an infection that's putting them in? Are they dehydrated? Is something else going on that's causing them to be in this? And I think it is tough pre-hospitally because it does take away. I mean, it doesn't take away their symptoms necessarily, but it, I don't know. Pre-hospitally, should we be giving cortisone? There's some people that will say I'll never give pre-hospital cortisone because if the person has normal blood pressure and good mental status, does it really matter if they're going at 150 for another 10 minutes? I mean, now we're talking if the transport time's an hour versus 10 minutes,
Right.
but if the transport time's 10 minutes, does it really matter if they're going at that 150 for
And
another
30
10
minutes to get the cortisone out of the
Right.
plexus and for the nurse to give it.
Exactly. So, I don't know what the answer is always, but it's definitely it's a good point, something to always think about. And I also think it's important not to just, like what Drew's saying, just don't see that this is AFib and suspect that it's new and say all of a sudden I need to slow it down. You gotta stop for a second and think what else is going on. With
Because
this
there's all these
person,
chronic
because-
AFibers out there. They get
Exactly.
fevers and get septic like everybody else, and they get 104 temperature. And what do they need for their AFib? Some Tylenol, right? They don't need like a drug, which maybe they have obstructive sleep apnea, cor pulmonale, and their cortisone will bottom out their blood pressure. Especially if their blood pressure's not 120 over 80 to start with. But I think the point you just made is really important for maybe like an SVT versus sinus tach too. If you give me, there's a lecture I have which is how to interpret the EKG without ever looking at the EKG, right? Because we all know that if you're telling me the patient's having new onset SVT and they're 80, my answer is probably not, right? You typically don't develop your first onset of SVT at 80 years old. You develop in your 20s or 30s, or women develop sometimes when they get pregnant because they're in a volume overloaded state. And sometimes you can't see whether there are P waves there or not because the rate's just going too fast, even if you're trying to slow down the paper. So, does a patient have a fever? Are they anxious? Those kind of, are they hyperthyroid? Those kind of like obvious things to figure it out. Are they volume depleted? What's the reason they have a tachycardia? And is this just a simple sinus tach? For all the times I was told the paramedics do that SVT is when the heart rate gets to be over 150, that is so incredibly wrong. I can put most of you at home, I can put you on a treadmill, get your heart rate up to 160, and you are not SVT, you are sinus tach. How do I treat you? I get you off the treadmill, right? I don't give you some silly drug like adenosine. All right, that's good. Anything else?
One other thing to think about, I think, with this, like, if this woman had chest pain and shortness of breath, that could either be an MI or PE still. It doesn't rule it out. But now, how many people would have given her nitro with her chest pain? And I think that's important to think about also in differential stuff, because giving this person nitro could have easily killed her, I think.
Because you would have preload reduced her.
You would have preload reduced her, you wouldn't have had enough
And
blood
this
flow
woman's
back to
really
the heart.
relying on a
And-
preload.
Exactly. And, I was talking to an EMT a few weeks ago who's actually asked me about, from a different state who was saying, I had this guy with he's like, do you give nitro to all your chest pain patients? I said, no, I don't think it really does much, in terms of morbidity and mortality. He's like, well, what if the person's having 10 out of 10 crushing chest pain? What if this? What if that? And I think nitro, potentially may help with some of the symptoms and stuff, but it's not this medication that we just give that like is a miracle drug. And
Nitro is not a miracle drug by any means. Let me say that to everybody watching. Nitro is good for two things, and number one is overwhelmingly acute to compensate a heart failure, and number two is some acute coronary syndrome. But in STEMI patients, there's a whole body literature that nitro hurts STEMI patients. That you don't dilate coronary arteries or proximal to fixed lesions, so you can actually create a Steele syndrome.
Yeah.
So some people from cardiology fellowships get trained not to give nitro for STEMIs, and I'm a big supporter of that too. People who are having chest pain need things like fentanyl, and they need some aspirin, and maybe some Brilinta and stuff like that. They don't need nitroglycerin, right? But
Yeah.
what we
We have no financial disclosures, by the way.
right, sorry. Right, yeah. They need direct thrombin inhibitors and factor 10A inhibitors, I should have said, sorry. So I mean that's what they need. The nitro does not help them. It helps people in pulmonary edema. But if you ask most people pre-hospital, they would say nitro is the right drug for STEMIs. And certainly if somebody gets put on a nitro or tridal drip who's having a STEMI and their pain's getting worse, I almost never titrate up the nitro. I titrate up the fentanyl.
Yeah.
Right.
Oh, and then one other point, and then I'm done for real. So when I talk to the interventionalists about this, and I think it's always important, especially for the ER people out there, to realize who you're consulting, what your questions are, and then doesn't mean we have to do what they say. Because I talk to interventionalists, so what does he tell me to do? Give aspirin, give heparin, give Plavix, give Brilinta, and morphine for this, because that's in his bag of tricks. So that's what they do. I didn't end up giving most of that stuff
So you
because
go to a cardiac interventionalist.
a cardiac interventionalist, and
I'm just curious, why did you do that? If you did that once the patient you knew the PE?
no, this was before the PE.
It was
initially just when I saw that I asked for the
Because
1 EKG,
EKGs
then
are
I
normal,
repeated
right.
an EKG, and I just kind of wanted to
Right.
let him know that while I wasn't convinced at this point there's a systemic, but just be aware that there's something going on here, and we may be calling you in a little while to let you know what's going on.
Right.
And what one of my teachers from residency always said was like, don't trust every consult. Basically, the consult doesn't necessarily know more than you. If it's in line with what you're thinking, then go with it. And if it's not, then think about it. It doesn't mean just because a consult says we have to do something or they want us to do something, it doesn't mean that we have to do it. We need to rely on ourselves and our judgment and all that kind of stuff. And I think it's important as well.
That's good. Anybody else have an interesting case?
So I've got a few. We haven't talked about the thoracotomy yet.
So Dr. Carr did. So Dr. Carr heard a 911 call go out. He drove, apparently head to the scene, lights the siren, I guess, and then already there was a gunshot wound to the chest and epigastrum. Already do a thoracotomy on the roadside, but heard they grabbed the patient and drove back to the hospital, where he entered the hospital and did a thoracotomy and opened up the guy's chest.
Yes.
A few feet outside the pre-hospital setting. So you were close to doing a thoracotomy on the roadside.
We were close. I was on my way to the scene. They lost pulses, and so they just threw him in the back of BLS ambulance and took him right to the hospital.
So
It was 2
shot
blocks
in the
away
chest
from
and
Jasper.
epigastrum and lost pulses en route to the hospital.
Yes.
So he was talking before he lost pulses.
I don't know if he was talking, but they had a finger on his carotid when they lost pulses. So.
Okay.
So
you
that's
should point the camera toward you for this.
I've got it on me.
Okay, okay.
My own laptop has a camera.
All right.
So basically, I started responding. I was finishing a clinical shift at Janus General Hospital, and I started responding down the road when I saw the ambulance coming towards the hospital. So I was still technically on the clock. It was a few minutes early, so I said, "What the heck? I'll go in and help out with the patient." So a few, I think, really important things to mention is pulses were lost probably 5 to 6 minutes before pre-hospitally. That's a good prognostic indicator. I think that the East guidelines currently, and the West, as they call the West guidelines, they have.
I know it's called East.
So they all recommend within 20 minutes, right, of pulses lost pre-hospitally, it's considered reasonable to try a thoracotomy. The other thing is, Kenji Inaba and et al. Had a study that came out 2 years ago now. Look at the heart before you go in. If there's a pericardial effusion, so let's say their study showed that in the absence of pericardial effusion and in the absence of cardiac motion, there's 0 survivability. So if you put a probe on the chest and you look and there's no effusion and there's no cardiac motion, you're done. I mean,
and we're big believers in that, right?
Yeah,
that
I
makes
think,
perfect sense to us.
And a lot of even major trauma centers are not doing that, unfortunately. So they, kind of make the determination based on timing and everything like that, and whether or not the patient had pulses when they came into the ER. Okay, that seems reasonable, but I feel like if you put the probe, so in this patient, we put the probe on the heart, we looked, we could see a big pericardial effusion, and we could see the heart was trying to squeeze. It wasn't, it was organized, it didn't have a great squeeze because A, there was no volume inside the left ventricle, and B, there was tamponade physiology. So it's like, yes, there's something we can do by going in, I think. So, so we decided to go in. What do you think the first medication you got was?
TXA.
So, yeah, I would like to think in a perfect world that's what he got. Unfortunately, I think the resident started calling for bicarb, calcium, and everything like that, so that might have been given first. But then we regrouped and we said, okay, Grandma TXA has priority, so he got TXA within 5 minutes of being in the hospital.
So what was going through your head at this point?
So, at this point, compressions were still being done, and I kept thinking, and I started verbalizing, there's no utility of compressions in a patient who has a traumatic arrest. I think for a few reasons. A, the reason they're not perfusing is because they don't have volume. So like I said, you looked at the heart and the left ventricle is empty. Doing compressions on an empty ventricle I don't think is going to do anything for you.
Right.
And B, tamponade physiology. So if there is a pneumothorax or a big pericardial effusion, it's putting pressure on the heart, not allowing it to squeeze that well. So if you're doing compressions on a tamponaded heart, what's that going to do for you? Absolutely nothing if you think about it. The heart's just going to be sitting there bouncing up and down. You have nothing to squeeze the left ventricle and push blood around. So I quickly said the utility of compressions is not going to do anything, and it's also dangerous. Once you decide to cut open the chest, somebody's sitting there with a knife and you're sitting there bouncing up and down trying to cut into the patient's chest. It's not safe. So finally, I think everybody was on board. We halted compressions, and we proceeded with the thoracotomy. We did left side first.
So you did left side first.
Yes, got in there, evacuated.
And how'd you do the left side? You just grabbed the scalpel and have some rib spreaders and all the usual stuff. Nothing special, right?
Yeah. Left side, 5th intercostal space. You just start at the sternum all the way down to the bed. You just follow the line of the costal margin. And we were able to get in there pretty quick. We got the Finichetto rib spreaders in there, opened them up, and
say that again. So
the Finichettos,
right?
Finichettos, that's what they're called.
So they're called Finichettos. So the ribs, you only call them rib spreaders in the movies. The medical people call them Finichettos. That's like the name we give it.
Dr. Finichetto.
Yeah, we got in there pretty quick. Opened the pericardial sac. Staying parallel to the nerve, the phrenic nerve, of course.
Because this is like a board question, the most injured thing that you have when you open somebody's chest is the left phrenic nerve, right? Question 63 on boards.
Always. It's if it's not on your board exam, then you take it to your examiner and you ask them why it's not on the quest. Anyway, once we got inside the sac, it was clot. It was fresh blood. It was all clotted. So we pulled that clot of blood out of there. And at that point, the heart was actually not moving at all.
Really? So it had stopped moving from the time you did the ultrasound to the time you opened the chest?
Yes. Somewhat miraculously, though, we were able to cross-clamp the aorta.
Any trouble finding the aorta? Or
so that's probably the thing that takes the longest on any thoracotomy. Me having done 2 within the last 4 months, I had an idea where I was going to be looking.
In 10 years, that'll be like 20 thoracotomies.
So what I found from the last one is that took the longest time to find the aorta.
Right, and I've seen very smart people who go into the chest every day cross-clamp the esophagus. Right, so this can be challenging, right? Especially if somebody's the heart's not really squeezing.
Did you patch the NG tube to help?
So yes, so that's one thing you can do. Drop the NG tube first, and that will help you because if you palpate the difficulty is the aorta doesn't have any volume because it's a traumatic arrest. So you're feeling it. It feels like the esophagus. It's somewhat muscular and it's squishy. The esophagus feels almost exactly the same, but if there's an NG tube in there, and even if somebody's moving it, you can identify that pretty quickly. For me, I found going posteriorly and feeling the actual spine of the patient you know the aorta's got to be just in front of that. If you look on a CT or an ultrasound, the aorta is just back. You have your spine sign when you're looking for the aorta. You can see the spine. The aorta usually sits just somewhere on top of that. So I felt the patient's spine, and then I went just anterior to that, and that structure did not have the NG tube in it. So that seemed like it was the right one. So we got that pretty quickly. Almost simultaneously, one of the residents fantastically got a subclavian corticin. So the big thing, I think, I didn't want
You point to the left side, but did they go on the right side?
No, they actually got the left side.
The same side you were with the
because at the same time, the surgical resident, we decided to clamshell. Because we got a chest tube
So
in.
clamshell means you open up both sides,
Right.
but typically we open up just the left side. So what made you the decision to do a clamshell and open up the right
So
side
I
as well?
left out
'Cause
a
normally
few
we don't
key
do that.
Right. I left out a few key details. First, the patient came in. We decompressed both sides with finger thoracostomies while throwing in chest tubes before we made the decision to do the thoracotomy. So that's important. On the right side, we did get a large volume of blood out. Once we got the chest tube in there, it pretty much filled up the pleural bag. So it's like, okay, well, most of the bleeding is probably coming from this right side. We evacuated the clot. We clamped the aorta on the left side. We still didn't have a heartbeat back yet. So surgical team started on the right side. They were able to get in and do the hilar twist. So they just grabbed the entire right lung and turned it on itself twice. And
Because they saw, what did they see when they went in?
they could not identify a site, but the volume of blood in the hemithorax on that side,
Massive.
it was massive.
So that's great. So they did a hilar twist just to see if they could compress, I guess, the pulmonary vasculature and just stop the bleeding.
Right.
Were you able to do like an auto transfusion or massive?
So that's the thing. We activated massive transfusion protocol. The blood wasn't really ready to go, but I verbalized that I did not want to push the button on the massive transfuser until we had the aorta cross clamped, because there was a GSW down here, and we had the hilar twist. That maybe took 2 minutes to do. The surgical team got in there quick, and they did it very quickly. And simultaneously, as I said, we got a left-sided subclavian. Once all that was up, we pushed the button, and you could feel the heart fill up with blood. So we were doing
Wow.
manual compressions, and we felt it fill up with blood. And then it started fibrillating. So the heart right in front of us, you could see it just started quivering. And it's like, well, crap, what do we do now? So if you look in your thoracotomy tray, you have these little paddles that you can hook up to your life pack and do direct contact defibrillation. Just like the movies. I didn't think we were ever going to do that in my life, ever.
So he's talking about internal paddles.
Internal defibrillator
And the
paddles.
reason we don't do this is because normally this scenario doesn't happen.
Right.
Normally we find something we can fix, or we don't find anything we can fix, and we get out. Typically people just don't start fibrillating in front of us.
Right. So we got the paddles, and they say, how many joules? Anybody? What do you 20?
So
I said 50, and it worked. So, I
mean,
remember
it's
hearing
not-
20 at some point, but
Yeah.
I just went right to 50, and I was like, well, I think that's a little much, but whatever. I had already made my decision at that point, and thankfully the first shock, it started beating, and so we could see the heart beating right in front of us with the chest open, and that was probably the coolest thing. So there was a moment of silence there, because I think nobody really knew what to do, because this had never happened before. We already had cardiothoracics on the phone. They were on their way in. Surgical team, they were on their way in. There were some delays getting into the operating room administratively. For example, they just wanted everybody in place before the patient got up to the OR, which is reasonable.
but in the meantime, you gave blood, you're given TXA.
We gave blood. He was
probably
alive.
give platelets, FFP,
Yeah.
some cryo maybe.
Yeah, we did one-to-one transfusion as best as
Yeah.
possible. So he made it essentially to the operating room. They closed him up, and he made it on his way to the ICU in transit. He lost pulses again. Unfortunately, they couldn't get him back. So
So just tell me what they found in the OR.
so massive, I believe it was pulmonary vessel damage on the right side.
Which makes sense.
Yeah. And so that hilar twist actually did something. They had a hard time reinflating the right lung after we did the twist. The hilar twist is like a dance. And they also had, I think they had actually a gunshot wound in the epigastrum. There might have been one down by the iliacs, because there was a large iliac vessel damage as well. So I think survivability was pretty low to begin with, but he survived to the OR.
But they made it out of the OR.
He made it out of the OR on the way to the ICU. I think he got to the bed and lost pulses again, and at that point they coded him for a while. But
Yeah, wow.
I'll call it a survival. made it out of the ER.
I mean, you made it out of the OR.
Made it out of the
That's
OR.
a big deal. How long were they in the OR for?
Hours, for I think about 4 or 5 hours.
Oh,
total,
so they were. So this guy is chest open for hours. I
Yeah.
mean, you never want your patients to get. You never want your anything to be open for more than an hour if you can try, right?
Yeah,
So
yeah.
you never want. I mean, two things to avoid: cold and patients being cold and patients being coagulopathic.
Another
And he
thing
was
that came
probably
up,
both.
yeah, he was. So we were warming him, but another thing that came up with the aorta should not be cross-clamped for more than 30 minutes. So we got to the 30-minute mark, and the surgery team, the OR was not ready yet. So we had to make the decision to unclamp the aorta. So we did, and surprisingly, his vitals stayed exactly the same. So I'm convinced that the TXA has stabilized all the clots in his lower,
Another
body,
case from TXA.
and that's what we reviewed that study, delayed death. Basically, the patients who did die took a lot longer to die after
So
they
this
got
is
TXA.
Ian Roberts' study, right? If you haven't read the London TXA study, you should do it. The senior author was Ian Roberts. I've been emailing back and forth with him, and although I think if you're listening, he's on vacation right now, so he shouldn't be listening. But for every, I don't want to misquote this, for every 15 minutes delay in giving TXA, survival goes down by 10%.
Yes.
So TXA is truly a pre-hospital drug.
Has to be given as soon as possible.
Right. That's great.
But that was a cool case. Mainly because we got to use the paddles, and
Right. And so the paddles, I mean, I don't know, the paddles just went right into the life pack?
yeah, they plug right into the life pack.
And you probably had a life pack 20, so they plugged right into the life pack 20?
You probably have the same adapter that you can put
Yeah.
on.
Right.
It went really.
Yeah.
So,
But I just know what's in the resuscitation bay is life pack 20.
yeah. So it worked.
Wow.
It was
That's
cool.
great. All right, you guys want to do some articles?
Sure.
The only thing I had interesting was I had a guy really quick who had, I think I was like 50, 55 years old with a couple comorbidities, an ugly looking EKG, 2 negative tropes, got a stress echo on him because it was the weekend, and this is in the RDU, and the stress echo showed no one motion abnormality. Because he was waiting for so long, I just said to the PA, just get a third trope on him. And the third trope, the first 2 tropes were 0.04, the third trope was 4. And so we got that back the same time we got back the echo, which showed no one motion abnormality. So the guy gets admitted, he goes to the cath lab, and sure enough, he's got 100% lesion of a branch of his LAD. And so he would have gone home if he didn't have that third trope, right? Because he had, and everybody agreed that the stress echo, and the stress echo is read by somebody who reads them all the time. So somebody with a lot of experience. And I just got that third trope because the patient was waiting and waiting and waiting. And
What's the utility you think of doing the third trope? Because I've seen some cardiologists that actually do that.
I don't know that I had any paper I was thinking of in my head to get a third trope.
Yeah.
I just thought that, and the reason I did it was because this patient's EKG was ugly. He had diffuse ST7 depression. We just had no old EKG.
Yeah.
We couldn't get one, and he had a bunch of comorbidities and supposedly all this heart disease from a different hospital. So we weren't able to get any records either. But I said I just wanted to reduce the likelihood that this is a cardiac event. Even with the stress echo, it still has some subjectivity to it. I didn't know who was reading, and the guy was waiting and waiting. And I'm like, well, we're sitting here doing nothing. Just get a third trope because, listen, the more tropes you get, the more you can reduce your risk. But, what do you do? Keep somebody here for 5 days and do tropes every 4 hours? It's kind of silly. So we try and do as few tropes as possible because we're doing one every, we're repeating a second one, and depends which paper you believe, somewhere between 2 to 4 hours, right?
Right.
So, and then of course we repeat the trope because the first thought is, I don't believe it's really 4, and then we repeat it again and it was 5. So, it's just to make you nervous though. But if this guy didn't have this story or this very abnormal EKG, I wouldn't have repeated the third trope and he would have gone home.
Yeah.
Okay, which article do we want to do first? Mike, want to do the nosebleed? So this is the second, the TXA. So this is. This was randomized, right?
Yep.
So this is the second randomized controlled trial of TXA for nosebleeds that I know of. So we have two pretty decent trials now with TXA for nosebleeds, and there are
Yes.
several others that are just not prospective randomized trials.
Right. So this one is out of Iran, I believe. Pretty large, fairly large teaching hospital. They actually looked at 2 teaching hospitals of about 40 to 42,000 patients a year. And this was, I'm going to put a picture of the article up here, but this looks like you got it ahead of press. So.
Yes, I did, because you can still get stuff off of PubMed sometimes ahead of press.
Right.
Or there are different ways to do it.
So here's a picture.
All of which are legal.
It's legal, yes. So here's a picture of the article and title with the author straight up there. This is the article that we're looking at. So essentially, this was a randomized controlled trial. They were looking at a specific patient population, though. This was patients with nosebleeds who were on antiplatelet medications like aspirin, Plavix, Brilinta.
And so it's the direct thrombin inhibitors and 10A inhibitors.
Right. So this is primarily a population who's going to rely heavily on forming a fibrin clot. A, because they cannot, I do that a lot, A, B, so anyway, because they cannot form a platelet plug to begin with, their body, in order to form a clot, you need to rely entirely on your intrinsic or extrinsic pathway in this case, so to form a fibrin clot. So I think this was a great population to look at. And as we know, the background, we review this every week because we always have an article on TXA, but this is an antifibrinolytic, not prothrombotic medication that's very cheap. It's very accessible. Everybody has it available to them, and we're just again trying to make sure everybody's using it for stuff like this. So traditionally, they were comparing a TXA group to a traditional route using anterior packing alone, just with cotton pledgets, as they call them, to pack the anterior nares. As we know, patients hate this. This causes a lot of discomfort, right? We're sitting there packing this stuff into their nose. Usually, and what they did in their standard group, usually what we do is we soak these cotton pledgets in something like lidocaine with epi, or Afrin or something like that, and in theory, you're going to get some vasoconstriction, and with the lidocaine, the patients might be able to tolerate it a little bit better. This is less than ideal. So, their study design, as we said, this was all randomized. It was a parallel group, and they used the injectable form that was 10% TXA. It was 500 mg in 5 milliliters. I think that's pretty much what everybody has, at least what we have available to us. And let's see. So their primary outcome was the proportion of patients in each group whose bleeding had stopped at 10 minutes. That seems reasonable. And it's good just to have one primary outcome. A lot of studies have multiple primary outcomes, and you can't really tailor your study to fit multiple primary outcomes. So they have one. That's good. Secondary outcomes: frequency of epistaxis recurrence in 24 hours and 7 days after treatment. That's really important. Secondary outcome was ED length of stay, and then third was patient satisfaction on a numeric scale. So. So what do you think the results were? I think we can guess. So they had 384 patients that were enrolled initially, and 124 subjects were enrolled after their exclusion, and basically, ultimately, they narrowed it down to 62 in the TXA group and 62 in the anterior nasal packing group. So the main results, let me just scroll down to table 2 at the bottom. Hang on, yeah. So table 2, the main results: bleeding stop time. That's a patient-oriented outcome. That's what we care about, right? So we want bleeding stop time less than 10 minutes. The percent in the anterior nasal packing group was 29%. TXA group, 73%. Was that statistically significant? Yes. That's freaking amazing. I think it's cool. All right, median bleeding stop time was 15 minutes in the anterior nasal packing and 10 minutes in TXA, also statistically significant. So discharge from the ED, they want a discharge time less than 2 hours. 13% anterior nasal packing group, and then 97% in the TXA group. Statistically significant. Anybody else amazed by this? I think it's really cool. Complications in the ED.
So they build less critical care time. So this saved the healthcare system significant dollars.
Right.
I'm from Iran.
Right, because I mean I don't know if they build critical care time there.
Right.
Yeah. So complications in the ED. It was only 5% anterior nasal packing and 10% in TXA. That's not statistically significant, but I was curious what they considered complications. I can't remember. Nausea, vomiting, and treatment intolerance. Those were considered complications. So apparently not statistically significant, but TXA, their N of nausea, vomiting, or intolerance for some reason was a little higher. Not sure that it matters. Rebleeding in the first 24 hours, 10% in anterior nasal packing and 5% in TXA. That was not significant, however. And rebleeding from 1 week was statistically significant. 21% with anterior nasal packing rebled in one week.
So that's very impressive.
And then 5% in the TXA group. I think that's because you put a big wad of cotton in there and you pack it tightly, and sure, bleeding will stop, whatever 29% of the time, but you yank it out when they come back for their checkup in 2 days, and all of a sudden that platelet plug, that clot, everything that's in there latched onto this anterior packing comes out, right?
Which begs the question, do people have to have bad nosebleeds to use TXA? Can they just have mild nosebleeds because their rate of rebleeding within the first week is less? Right? So even if you stop a nosebleed very easily in the emergency department, if their certain percentage will return or get more bleeding, then maybe more routine TXA for nosebleeds is a smart thing to do.
The only thing I didn't mention was we didn't go over the patient characteristics in Table 1. Everything's pretty much the same except the TXA group. History of epistaxis. They had a pretty significant larger number of patients who had a previous history of epistaxis. So seemingly more severe or refractory to treatment previously in the past. So I'm not sure if there's a little bit of bias there. This was randomized, but maybe it just turned out that way, that patients who are getting TXA, they were just more prone to epistaxis in the past. So I'm not sure how that happened.
Yeah, that is kind of weird. Maybe the author can tell us, because that is... do we have anybody from Iran on? Before we had Finland.
I don't think Iran's on.
I mean, we can ask Dr. Reza. So, because if you're randomizing people, why is it there was so many more? Of course, we have no p-value there.
Right.
But why is it twice as many people had epistaxis before? I mean, it could just happen by chance.
Yeah.
It's an interesting question. I'm not sure. So does this change your practice?
So I work at a hospital, and the pharmacy department is convinced that I have some kind of financial vested interest in TXA, because I get emails on a regular basis about using it in patients where it's not indicated, in patients who are not traumatic and everything like that, because the hospital protocols currently are in the Stone Age, and they think TXA should only be used for traumatic arrest patients, traumatic hemorrhage, anybody who's they're activating massive transfusion protocol on. I think it's, as we said, topical use in addition to any patient really with major bleeding is really indicated. So it's great. I don't know if you guys use it at all, but when even people who come in with lacerations who are on factor 10A inhibitors or are on NOACs or on any kind of DOACs, yeah, or on any kind of blood thinners, it works. You put it on top of the laceration, put your dressing on. It does not bleed through the laceration, and a lot of times they come in because they're like, oh, it's not a bad cut, but it just won't stop bleeding. They've had multiple dressings applied. They've been applying direct pressure at home, just like their doctors told them to on the phone, and it's just not bleeding. Or it's not stopping. So I don't know. I think it's cool.
Right.
Naturally.
Do you need these people with the packing, or do you just take it out after you find the cessation? That's the question I have. How long do you leave the packing in for?
So when I've used it for epistaxis, I soak, the tampon equivalents in the epistaxis tray. I just take one of those.
Like rhino rockets?
No, so they have these little, they look like tampons. They're just like, they're cotton pledgets, I guess.
They're pledgets.
Yeah. I just soak that in TXA, and I just shove it up there. I come back in 15 minutes and pull it out. and every time I've done that, the bleeding has stopped. That being said, I've not used it on a posterior bleed before.
Right. So the
I've
question
only
is,
had one
why not
posterior
say,
bleed
if
in
they
my
had a bad anterior bleed, why not just leave it in? Besides the fact that that's uncomfortable. But I
Yeah.
guess I wouldn't leave it in if I knew it wasn't going to rebleed. But if you did a study and showed me I have a very high rate of rebleeding, if I take it out, then I would leave it in. But until then, I guess I would take it out.
The question is, how long do you keep it in? And in
Right.
general, my practice is 15 minutes, and that's just a made-up number
Right,
that
right.
I've created. So I mean, but
Right.
the question is, what should be?
But what about the guy who's coming in with massive nosebleed? You're trying everything fails. You go to TXA. Are you going to take it out then and just send the guy home if it stops, knowing that the nosebleed was so bad? Or
Interior?
Would that interior? Well, anterior, because
Yeah.
we all think about posterior being so bad, but
Right.
an elderly person cannot take an anterior nosebleed and they fall asleep at night and
Right.
Yeah.
they can still die from that.
I mean, the question is that the utility of a packing is going to be more of a bulking kind of a more pressure from the perspective. The TXA, after a while, it's going to dry out, and the cotton's going to dry out, and so the actual medication application is no longer
Right.
there. So the utility of actually having that packing there from a medication perspective is, I think, not there. It's more be just a bulking dressing that's causing some type of compression against the actual point of bleeding. The question then becomes, can you do the same thing that you're saying? When you actually dry this now packing out, you're taking this gauze out or this budget out, can you take out this plate of gum that you created?
Right.
So, I mean, there might be a risk that you kind of expose the patient to when you actually take this out, but they're not going to be taking this out on their own. They're going to have ENT take it out at the end of the day.
Right, or they sneeze hard and it falls out by themselves if you don't
Right.
pack it well. Yeah, I guess that makes sense, because
So
going home with the interior packing is terrible.
And it's going to come out at the end of the day. That's going to naturally come out. Versus a Rhino Rocket, they're never going to touch that, and they're never going to take it out on their own.
Right. Right. But I've never had a patient who I inserted like a Rhino Rocker or something and said it wasn't a terrible experience.
Oh, it's always a terrible experience.
Yeah. All right, that's great. What's next? Want to do the next article?
I can do the continuous compression versus compression and ventilation.
Oh yeah.
And does it affect the title? Or does it affect survival, which they give away the title?
Right. So what a mess this literature all is.
Yeah.
We still have no idea in 2017 or make it 18 how to do CPR. Go ahead.
Right, so this is this paper by, I guess you say, Ashore and resuscitation. And basically they started out with a question of, in patients with cardiac arrest, what's the effectiveness of the different compression to ventilation methods during CPR. Essentially they're looking at doing compression only CPR and then compression with two ventilations, 15 to 2. So what they did is they basically looked through Medline and Cochrane for all their randomized controlled clinical trials. They also looked at some observational studies, but that found that they had too low of a grade, so they didn't include them. They basically only looked at the randomized control trials. They came up with 4 that were one was 3 were adults and 1 was combined adults and children. And basically I'm just trying to find the actual numbers. They had the 2 types of papers essentially. One was the randomized control trial where 911 dispatchers were instructed to talk to whoever's on the phone, telling them, hey, this person's not breathing, they have no pulse. And then the 911 dispatcher was randomly assigning only compression, only CPR instructions over the phone versus 15 to 2 compressions to ventilation. And the end result was that there was no difference in favorable neurologic outcome between compression only and 15 to 2 ventilation. And
Drew, what is going on?
Yeah.
Is everything we've learned about pit crew CPR and continuous compression is totally wrong?
I think
How could that be? We're teaching everybody out there pit crew CPR to not stop.
Right.
And now you're telling me, although the nickel paper taught me this, and the CCCPR paper in children taught me this, that there's no difference between stopping to ventilate and continuous compressions. Did you guys hear that? Everything you've learned about continuous compressions is wrong. Is that accurate?
I think that's the back and forth. The most important part is this is actually talking about lay people. These are all the randomized controlled are lay people, and so they even mention that in the paper. There's no high quality evidence that we should be doing compression only as trained medical personnel. I think that is different, and also that kind of makes just intuitive sense. Random people on the street maybe are less likely to do CPR if they think they might have to do like mouth to mouth CPR. That might be just their perception.
So for every first aid squad that's doing compression only CPR,
there is absolutely no evidence for that.
There is no. Let me say that
There's
again.
not.
There is no evidence to support that. In fact, the evidence says the opposite.
Right,
that
definitely.
you need to
You
ventilate.
need ventilate. You need to be ventilating.
Right. This is not Mark Merlin's opinion. This is the science's opinion. Right?
Absolutely. That's pretty clear. I mean, then they had these large. I mean, the end of these pooled randomized control trials was 23,000 patients. And that's definitely a large N.
And this is consistent with the paper we just reviewed about cardiac arrest in children, which showed that CPR, compression only CPR, was inferior to ventilating with compressions. And the nickel paper, though, the only prospective trial we ever had that is now a couple of years old, maybe 2 years old or something, which showed that people, although it was certainly the study had issues, it was still the best study ever done. It had issues, but the best study ever done, which showed that you have to ventilate a little. I don't know what to tell people now.
Right, it's
How
definitely
could this
a back
be
and
right?
forth.
Jim, how could this be right? What do you teach people? I mean, somebody help me. Is there anybody at home who's writing in?
Not that anybody's commenting right now.
I think and probably why it was such a there's several randomized trials is that on the phone for a dispatcher for a presumably untrained medical person, it's simpler and you're more likely to get compliance if you say just push on the chest, and it's probably easier for them to do rather than to be in this very upsetting emotional state. It's probably their own loved one there. It's probably just simpler, but I just don't think that's not the case once you get trained medical personnel there, because that is the medical training that we have.
Yeah.
I think that at the end of the day, it's still compressions are better than no compressions. As long as you're
So I guess, so do you agree that if you train lay people, you should train them in compression only CPR because they can't handle compressions and ventilation? I mean, that's the argument. When you go to the mall and you teach people, or at least teach, I mean, we know that for children you should teach that, but for adults, if you do CCCPR, you should teach them compression only CPR and not have them ventilate because they might get confused. You buy that?
I don't know, I just think the evidence of just doing compressions, I mean, all the studies we've looked at from PIT CPR, compression only CPR, layperson CPR, the bottom line is the sooner you can start compressions, the better off you are. And I think that's the one thing that's run through this solid as evidence in all combinations or
So if you were writing a protocol today for an EMS system, what would you tell them to do?
I think
Before they intubate.
compressions as soon as possible to maintain the circulation until we get it started. Using advanced measures. The more training you bring to the table, you get practice to your scope.
And what would you do if you're training a bunch of security guards at a mall? What would you have them do? Would you have them ventilate or not?
I would have them ventilate if they had the equipment. If they had a back valve mask, they would use it.
I think that's what we run into with like lay people. They don't have the exposure to using a breathing apparatus or a breathing device like a BBM. So their options are using a filtered one-way valve, mask to breathe, do mouth to mouth, or even if they don't have that, you're asking somebody to put your lips on another patient and hope that your family member doesn't have a disease or something like that. And nobody's gonna do that.
So let me ask you this: you guys probably take a day off every now and then. You're at the mall tonight. You're walking through the mall. You have no equipment with you, nothing. You're in the middle of the mall, far away from any vehicle, and you stop and somebody goes down. Are you going to do compression only, or are you going to do compression with ventilation?
So I have on my keychain a one-way valve.
No, you left your keychain at home.
Changing the
So
rules.
no.
Even if I had the keychain, unless this is a young child, I would be doing compression only.
Yeah.
You'll be doing compression
I
only.
would be doing compression only.
And I would just position the head so you have an open airway. I mean, we have a lot of data that says air exchange happens even in the absence of ventilation, so I'm going to rely on that.
But then somebody at home is going to say, but the article that you just reviewed in Therapeutics in 2017 said that you should do ventilation too.
I'm not going to change my practice unless there's a randomized controlled,
Never have.
But we started supporting picture CPR without a randomized
I
control
know.
trial. We started supporting with observational trials only.
all I've ever
And then when
known.
we got the nickel paper, which was better statistically, which was not an observational study, we said, we don't like this paper, even though it's the best one done, let's keep on teaching picture CPR. So we're ignoring the evidence now
Yeah.
by doing picture CPR.
I don't know what the answer is.
So then you start doing compression only, and now a second round cure comes. Lay person, what are you gonna have them do?
I mean,
No equipment.
Yeah. Sure. If it's the second person, they can ventilate. That's all up to them.
So they can
yeah.
ventilate. And you're gonna do that you're
Swap
gonna
out
do that
so
whenever
no
they
one
want
affects
to, right? You're not gonna like stop compression.
I wouldn't stop compressions,
Right,
no.
right. So you're gonna just tell them to ventilate, and you're just gonna how often are you gonna tell them to ventilate?
I mean, if I can, in reality, actually convince them to put their face in this other person's face, sure, probably 30 to 2 because they're more likely to do 30 than they are 15.
All right.
I don't, for
You'd
no
probably
good
be better
reason.
off to be relieved
I mean,
on compressions. 'Cause if you're doing compressions for an extended period of time, we've looked at several papers that you're not able to do it well
Right.
and effectively for a long period of time. You're better off having that person swap out from you
Right.
and continue the compressions.
Right. So you're gonna have that person swap out for you because once you get tired,
And then
that's what you're saying.
somebody in
right,
an
and
AED.
that probably is going to long term have more impact. Good, solid compressions while someone's getting that AED as quickly as possible. That probably is impacting
I
survival.
think you brought up an interesting point. You said with a kid, you'd breathe in a kid because most pediatric cardiac arrests are respiratory or
Maybe, but I breathe in a kid because the CCCPR is worse in children and better in adults.
you breathe in a kid too. It's a primary etiology. The rest is
Well,
left
that's
to
the
the
argument of why that article showed that CCCPR lost, because maybe most of these are respiratory. That sounds like a reasonable argument. I don't know if it's true, but it sounds like a reason. Or we got the adult data all wrong.
But
One
we
of the two.
also know that you have good oxygenation status in patients who are actually in cardiac arrest. Initially, right off the bat, that they actually do have some, core, PO2 in them. So you can actually do continue CPR for a good amount of time without, really kind of making this patient hypoxic at the end of the day.
basis of the 600 seconds or whatever.
Right.
600
Yeah.
So I mean, you know that after 4 minutes, you kind of see this drop and a precipitous drop in basically your PO2, and then at that point, then ventilation actually becomes a little bit more important. But I mean, until then, I would start off immediately with continuous. That would be my mantra, and I probably would do that until I can get early defibrillation, and then I can actually get maybe a mechanical device.
So you guys have all bought in to picture CPR and continuous compressions because of the. I mean, the thing I always quote is for every 5 seconds you interrupt compression, survival goes down by 17%.
Right.
But you have a nickel paper that says it's not true. You have a CCCPR children that says it's not true. You have therapeutics this month, which looked at all the article, which mostly they looked at the nickel paper. But I agree with you. I just am hard pressed to find evidence in literature that says I'm doing the right thing.
Right.
I think if we have the capacity to breathe for people, I would do it. I mean, if I'm in the mall and I don't know whose face that is, I
Not
may not want to
happening.
put my face on their face. But
Not
if I
happening.
have someone that comes with the bag, with the bag of death, I will use
You
it.
would do it.
I would use
And
it.
now they say to you, how often should I? So if you're doing compression, somebody says, how often should I breathe? What are you going to say?
Yeah, I mean, I think
Because what I'm thinking in my head is, well, you're asking me a question based upon no science, sir. So,
Right.
But they don't want to hear that when their guy's down. I would just say count to 5 and breathe.
Yeah.
I would just say something as simple as possible. Because what I don't want is them looking at their watch and doing
Right.
every 6 seconds. Right.
Or breathe every time you breathe, or something like that.
Right. Except that guy's the captain.
Right.
All right, that's good. So I don't know. Any other thoughts about this? What a mess.
We don't know what's going on. Maybe.
I just think the mantra through all this, the gross meta-analysis of all the CPR data is early, high-quality CPR. Early, high-quality compressions makes a difference to all these speakers. You gotta get somebody pushing.
Right, and I would add with some ventilation at some point, right? Because no ventilation probably doesn't seem to be the way to go.
I think intuitively it makes sense that you need some new oxygen coming in
Right.
at some point.
And it
There's
is
some passive flow from doing the compressions. And then
right.
theory
it's probably important in everybody, but people who go down in front of you probably are at least some of them are probably well oxygenated to start.
So maybe the question is that, right, so they're well oxygenated, and then maybe all you need to do is really open the airway, because if you have them with their airway closed and you're only doing CPR, then they're not getting any air from the passive compressions. But maybe if you open their airway and do compressions, then maybe you actually are getting some more oxygen, so maybe that's like a bridge between the two.
Yeah. Okay, what's
But
next?
who knows?
Which article is next? Anybody?
I could talk about battlefield to bedside, translating wartime innovations to civilian emergency medicine.
All right, I like this.
I like
Turn the
this
mic
too.
towards him. Josh is very soft-spoken.
I'm
This
trying
is
to
a-
speak louder.
We can pull
This
it
is
up to you.
American Journal of Emergency Medicine by Melissa Givens in Bethesda. I like this article.
I like this too.
Congratulations, Melissa.
Yeah, I like this too, also because we're doing all of this stuff already.
So this basically is a review of a lot of different things.
Yeah. I thought this was cool stuff, and I think it's good to kind of have, a bridge between what's going on when the Army, where they're, dealing with all these traumatic injuries all the time, and what we see in the ER, and, unfortunately with the world events and what happened in New York City, and, there's war being brought to us, and we need to be able and be well-versed in these different things and how to care for people. Both pre-hospitally and in the emergency room if someone comes in with these traumatic injuries that we don't really see every day. So this basically is kind of like a review of a whole bunch of different things and various different topics within the literature in different traumatic situations and wartime innovations, like the title said, and how we deal with it in the ER and pre-hospitally. So we'll kind of just go through this stuff quickly. I mean, hemorrhage control. They saw that a lot of people were dying from bleeding out, and the military realized we got to do something about this, and they felt that it was preventable, all these deaths, and based on different hemorrhage control techniques, they found that there was a huge rate of survival. Survival got a lot better, and morbidity and mortality as well. So, I mean, tourniquets, if we look throughout the literature, at times tourniquets were in vogue, then they were out of vogue, and now they're kind of coming back. But if we look here, I mean, at the bottom of the first page, it talks about how in the Iraqi and Afghanistan wars, that's really when we started using tourniquets again, and there was a paper by Craig et al. Reported out 499 patients and used 862 tourniquets. There was a survival rate of 87%, and despite the liberal use of tourniquets, the morbidity was low, with under 2% occurrence at palsy of the level of tourniquets and 0.4% incidence of limb shortening. So, I mean, that's pretty remarkable, I think, and if you're going to save 87% of lives and have, less than, minimal morbidity from it, that's a great intervention. If we look at the next sentence, it says, a study finding underscored the importance of early use of tourniquets with a survival rate of 96% when applied before the onset of shock and just 4% when applied after shock had ensued. So now we're talking about having tourniquets all over the place. When we were at the, where people are carrying tourniquets on their belts with them, and I think if you can get this tourniquet onto someone before shock and you have a 96% survival rating versus 4%, this is something that we need to be doing in the field. EMS needs to be doing this, and and then if civilians happen to have tourniquets on them and they see and they're at some event or something happens, I mean, it seems like there's very little downside to putting a tourniquet on someone. I mean, if we think about when we go to the ER, when the orthopedics take people to the ER and they put tourniquets on. The OR, sorry. How many hours are these tourniquets on while they're doing these surgeries? Take off the tourniquets and people's limbs aren't ischemic. And if it's going to save someone's life, tourniquets were once thought of as a big bad thing that, you have to write the time on the person's forehead and, all this stuff, but maybe it's really not as bad as we thought it was, and it's definitely something to consider.
Even now, like IDF and stuff like that, they're putting the tourniquets they're built into the uniforms. So you just pull and tie, and it's like, it's already ready to
All
go.
these SWAT guys carry tourniquets all the time.
Right, SWAT teams have them all.
So what's your game plan? I mean, you're pre-hospital tomorrow. Somebody pull up on the scene. Somebody says, right before you got here, the guy had a laceration. It was terrible. It was right down to the bone. His arm was cut off, and they have a dressing on. And now you're in the middle of a highway. right? And he's got a dressing on.
Yeah.
What's your game? What's your approach?
I mean, I think I want to feel for pulses on this guy. If he's got a pulse,
So he's got pulses.
If he's got pulses and it seems like the bleed is controlled, I mean, depends on how big and bulky the dressing is. But if I see bleeding coming through it and the guy is, if I think the bleeding is not controlled by this, well, first of all, it also depends on how many people I have. If I'm by myself and there's other people, I may be more inclined to put a tourniquet on this guy and then just go, because then I can not have to worry about him. If I have a whole bunch of people, I may ask someone to hold pressure for a little while as opposed to putting on a tourniquet. So I think it probably depends on the situation. But
yeah, and I think I do the same thing. I mean, if the dressing isn't too big and bulky, and you're not losing a liter of blood in it, it's a thin dressing and it's not bleeding through, and it's got distal pulses, I just say, especially if it's multi-system trauma, I go, who cares? Let's just go. Right. And if no matter what they say, and if it's starting to bleed through, then I'll take it down. I'll look at it. I'll maybe put TXA on. And oftentimes, what I can do with like 2 fingers to stop bleeding is much better than a whole entire tourniquet. And if it looks like a bad arterial bleed, then I can put tourniquet on, but then sometimes I can put TXA on if you're bleeding through the dressing.
Yeah.
But if you're multi-system trauma, you're not bleeding through, and it's not a big bulky dressing, I'll just let it go.
Yeah.
Right? If it's a big bulky dressing, I'll take it down to like 1 or 2 layers, just so I can make sure that it's not going to be like a typical headlock where it's a little tiny vessel which has 2 liters of blood in it, and they have a big bulky head dressing on, which makes no sense.
And these big bulky dressings that we see put on aren't doing stuff half the time.
They're
They're
not
just
doing
on there.
anything, right.
So why do we keep on adding on
Most
more and
bleeding
more
can be
and
stopped
more
with
and more?
one finger,
So
right on, forget
Right.
about the 4x4, a 2x2, right in the area for
Exactly.
a second, done correctly, right? And you guys haven't had it, but every fellow has had somebody exsanguinate from a ruptured fistula because somebody didn't hold direct pressure good enough.
Mhm.
Yeah, the big thing that they're saying is the big bulky aggression soaks up all that blood, and you don't know how much blood you're losing into that.
Right.
So I will try to hold pressure above, kind of like a temporary tourniquet type of thing, take down the dressing, and then slowly release to find where it's bleeding from.
What I find pre-hospitally too is the big bulky dressing, and then so the first thing I've decided I'm going to do is take off that big bulky dressing, because a lot of the times they say they have the tourniquet on, and it's just not tight enough.
Yeah.
So you take
Right.
off that big bulky dressing, and there's still a significant amount of
But
bleeding.
you agree
so
if it's a thin dressing and they're not bleeding through it, and it's a multi-system trauma, you're probably not going to focus on
You
it.
can
Right.
move on. It's not a
Yeah.
life-threatening injury.
Right.
Yeah.
But unless they're entrapped, if they're entrapped, then I may look at it because I may say, you know what, I'm not going to get to this very easily. Maybe I just want to do a figure 8 suture in it, or put TXA in it, or inject some epinephrine into it. Or
Yeah. One of my favorite things is the manual blood pressure cuff, because you essentially use that as a tourniquet. You can see how much you increase your pressure to. You have time to work on it, and then you can slowly deflate it and see if your intervention has been successful, whether it's TXA, whether it's doing a whip stitch or something like that. I use that in the ER all the time for fistula bleeds.
Right.
So.
And you don't
And then
want-
if it's still bleeding, you pump it back up really quick, so you don't have to sit there and tighten the tourniquet again.
Yeah. Okay.
Then there are some areas where tourniquets aren't good at the junctional sites. So if you have something in the groin, let's say, or potentially up by the shoulder, any area where you can't really get a tourniquet on, and there's hemostatic agents, and there's a whole variety of different stuff. We talk about quick clot, kaolin, Celox, Cheeto gauze, Xstat. So it's kind of all different stuff that we have. And they talk about here how the Israeli Defense Forces, they report an 88.6% success rate in the control of junctional hemorrhage. And that's important because these junctional hemorrhages they're very, very difficult to stop. And unless you have someone that's going to sit there and be able to hold pressure and be able to hold pressure, then you need to get something else. And just a quick story: I was in the alleyway with some guy who's a stab wound about this big in his groin, and he had a bottle of vodka in his hand, and he started pouring it on his head and trying to drink it, and wasn't really clear what was going on. This tiny little stab wound. Next thing I know, the guy is dead on the floor. And from what I think, when he was drunk, holding his vodka and pouring over his head, he was probably just hypoxic and bleeding out from this tiny little thing in this junction that wasn't even spurting out, just bleeding out into his thigh. So these things can potentially help people and can potentially save someone's life.
I agree. We need to start getting just as nervous about bleeding that we can't see as bleeding that we can see. We all say there's blood all over the place. I'm really nervous, and I go, don't be nervous. I can see it. This is good.
Yeah.
It's when that young person has a ruptured spleen that's bleeding internally that they have normal vitals that you don't get nervous about. You should.
Yeah.
have you ever seen the utility of like? So they have these like the tourniquets that you can put like at the joint spaces, like these larger ones, the pneumatic ones even. I mean, you know, they're fancy, they're expensive. You know, I mean, I don't know what the utility of those are, but they're out there. You can also use those as well. They have abdominal tourniquets, pelvic tourniquets, but you know, they have the one new ones out there, the SWAT tourniquets, which I think are pretty inexpensive, but I have good utility.
Yeah. I mean, I like the soft T and the cats, but I know what you're saying. The abdominal ones or the
one that's inexpensive is the SWAT T tourniquet, which is more of the elastic band, and so basically it stretches really nicely, and you basically just keep wrapping it around. So if you got something that's a little bit higher up that you can't get the tourniquet at, or you have a patient who's got a rather large limb, I mean, you know, you can get that tourniquet on, and you can actually get a good amount of like pressure on there with the SWAT T tourniquet. And that's what we carry on our canine bags, because the canine limbs are a little bit smaller, and we can get up a little bit higher with the SWAT T tourniquets. So that's what we have in our canine bags. But I mean, you know, I think those are really good tourniquets, and they're inexpensive. Only a couple bucks.
Really?
Yeah.
So the dogs get the inexpensive tourniquets and the TXA, and the people get nothing.
Right.
Good.
My wife's not watching, but I'll have her comment on this thing.
Oh yeah, I've seen these things. They've been using them when I volunteered for the ambulance in Israel years and years ago. They were using these things. It's basically just like it's just a rubber band. Basically, it's a huge rubber band that you wrap around.
And each time you can tighten it in.
It has squares in them, so you want to stretch out the squares.
Right.
Yeah.
So they come in squares, and that's how you know if you're stretching them enough. Is when you see the squares become pretty much oblique and separate.
Yeah.
I keep going.
Resuscitation. So in the civilian population, we see 2 to 3% of traumatic patients require MTP, massive transfusion protocols, and then in the military, up to 8% they require massive transfusion. So it's a great place to kind of look to see what we should be doing in terms of massive transfusion protocols. And again, fluids, crystalloid fluids are not good. There is a much greater incidence of abdominal compartment syndrome, organ failure, and death compared to resuscitation with blood products. So, you know, talked about
Sounds
this.
like another disease I know called sepsis, maybe.
Yeah.
Because you dilute out clotting factors because nobody bleeds normal saline, right?
So, you know, we talked about, it doesn't talk about it in here, but we've talked about the 1-to-1 to 1 ratio. And, you know, basically here they recommend a move from using crystalloids to blood products. So if you're resuscitating traumatic patients with crystalloid fluids, you're probably doing the wrong thing, and they need blood. They lose blood, they need blood.
So anybody who you see who's dying in the ER from a bad trauma, you're giving blood, right? They hit the
Absolutely.
door, right?
Absolutely.
And it doesn't matter what their hemoglobin is. If you see tons of blood all over the place,
Right.
they're really bleeding out. None of this matters,
Yeah.
right?
Yep. And blood products, which are the best blood products to use. So this is actually a little bit interesting in here, which we're not doing everything kind of they talk about here. There was a study, Spinella et al., compared using the warm, fresh whole blood to component therapy in combat casualty patients, and it said, you know, the patients who received warm, fresh whole blood got an average of only 30%. And 70% of component therapy. However, the survival rate was better than patients who had received component therapy alone. So, you know, maybe there is some role for warm, fresh whole blood, although that seems to be, at least in the civilian population, a huge issue. How are we going to get warm, fresh whole blood from people? Are we going to have people waiting at the door to donate blood for the traumatic patients?
Because the military can do walk-in
Right.
blood banks, right?
Exactly.
So they put a call out overhead when they needed blood, and they get all these healthy young recruits. The problem is healthy young recruits have been screened for all these bad
Right.
diseases,
Yeah.
which are people in the civilian world haven't been, and they can get blood from them right away, and then they can do walk-in blood banks, which is what they do, right?
You know, so here they say 250 patients who receive a massive transfusion. The higher the plasma ratio in the blood, the lower the risk of mortality, and thus recommended, like we just said, the plasma to RBC ratio of 1-to-1 for massive transfusion protocols. And then this was actually, you know, reproduced in civilian population. So this is something that we need to be doing as well. So we all do have the component therapies. We shouldn't just be giving the PRBCs. We need to be giving the platelets and the plasma as well to people. Talked a little bit about freeze-dried plasma, which we had talked about a couple of weeks ago in an article. You know, there are places that are using this. I don't think there's any products that are available by the FDA in the United States at this point.
But once there is, we'll all start using it, right?
That's right.
Because you don't need to refrigerate it.
Yeah. TXA, CRASH 2 trial, MATTERS trial. We talked a lot about TXA. TXA is good for trauma. I don't think we need to say much else on that at this point. IO devices. Should we be using IOs in trauma? So now IOs seems like they were probably developed by the military in these traumatic situations. We go to them very quickly, at least from what I've seen from my experience for cardiac arrests and for stuff where it's hard to get IV access. But now you have a traumatic patient that's coming in. A lot of traumas are young, healthy people generally, so they do have good veins. If we can get a good 14 or 16 gauge needle in there, that probably is enough. But what if we can't? How? And what if you're the only provider there? So if you're in a residency program in a trauma hospital, we can get IVs in pretty easily. But let's say you're the only doctor in a small community place or out in nowhere. Possibly using an IO can be helpful. Putting a sternal IO, a humeral IO. Thank you. A humeral IO will help as well. The flow rates are much higher in the humerus than in the tibia. So this is something that we have, and it is a very good tool to be able to use. Airway management we talked about is the next thing to talk about. Airway compromises, they talk 1 to 2% of battlefield fatalities. So it's very rare that we're performing crikes. However, it does happen. Probably happens a little bit more in the military than in the civilian population, but it's either way, it's not happening much anywhere. The military has a higher failure rate, they said here, compared to civilian reports, but the military is having EMT basics do cricothyroidotomy, so maybe that could be potentially, although assuming if they are trained well enough, then they should be able to do it. But there's also a whole bunch of stuff that they're dealing with in the military. I don't know how easy it is to do a cric with bullets flying over your head, as opposed to in an ER where people are just screaming and hopefully there's no bullets flying. So I would have to imagine there's a lot more stuff going on. You also have a lot more gear. Your hands are tied up. You got your huge vest on, helmets, and all this kind of stuff. So but it's also important to think about. The airway's not going right, if your intubation not going right with the trauma patient or even a medical patient, get ready. Having thought about how to do a cric and just practicing it in your mind or practicing it on dummies is important, because when we're in the situation, you've never seen it done, you've never heard about it or never practiced it, it's a lot more scary than doing it, having heard about it. Pain management. So, pain management is always a big topic. We want to be able to treat people's pain effectively. And also we need to be able to treat them medically effectively. And there can sometimes be, a fight between the two. So how do we do that? And especially in the military, where, again, it's austere conditions and, it may not be so easy to get IV access. So what's the alternative? They were using morphine for a long time. In the military, but again, you needed some IV access for that. So here in the wars in Iraq and Afghanistan, they had alternatives. They had oral transmucosal fentanyl citrate. So this is basically giving, which I actually thought was pretty cool. They would tape a lollipop to a person's finger. He would, or she would, be sucking on the lollipop with the fentanyl on it, and then they said if the person became too sedated, the lollipop would just fall out of their mouth, and that would be that.
Would they pour the fentanyl on top of the lollipop?
Well, I think they're fentanyl-made lollipops.
Oh, they're fentanyl lollipops.
Yeah, you can get them in your local CVS.
Right. I'm surprised they have diversion problems in the military with fentanyl lollipops.
I thought they got rid of those fentanyl lollipops.
I don't know.
I thought a bunch of ERs got rid of them. Maybe the military.
Well, in the civilian world, we got rid of them, but they still use it.
In the military?
But they only issue it when you're deployed.
In some of the
it's accounted for.
In some of the hospitals I work in, I type in fentanyl. It says fentanyl lollipop on the order
Really?
sets.
Well,
I don't know if they have them or not, but
it's mostly for pediatrics.
I keep on wanting to order it just to see if they have
The other thing that's nice though is you can use nitrous oxide, at least in the civilian side.
Yeah.
But carrying a compressed gas in the military.
Maybe over here.
Whippets.
All right, keep going.
And then so that is potential. I don't think we really have. Our access to this in the civilian world isn't so much, I guess. But if your hospital happens to have it, or if your EMS agency has it, then maybe it could be. And then ketamine they talked about. So at sub-dissociative doses, and we've talked a lot about ketamine. It has good hemodynamic effects. It doesn't cause people to be hypotensive, and given in the right dosing, people can really be with it and get good adequate pain control. So it's another thing to kind of think about that we are using here and pre-hospitally for pain control. In our sites, we're doing that, and it seems like they're doing that in the military as well. So, talked about quickly a whole bunch of different kind of quick things that.
You just said pain. I just love this sentence. One major adverse effect, hyperventilation, was noted in a patient who received high doses of fentanyl, 3,200 micrograms, in addition to 20 of morphine. You got 20 of morphine and 3,200 micrograms of fentanyl.
That's what in a patient.
Over
Yeah.
how much time though? They didn't specify.
Yeah.
I mean, it was an acute injury. I don't know.
It's a lot.
I mean, generally for an acute injury,
It's
I
impressive to have that much available. 32 vials of fentanyl.
like you give and then you reassess and then you give more.
Anything
yeah.
else, Josh?
No, I mean, I think like a lot of this stuff we have, a lot of this stuff is available to us in various different places, and even in the smaller hospitals that I work in, this stuff is there. So, we can potentially use this. We just need to know about it and be able to kind of translate it from using just medical stuff to trauma stuff and to kind of expand our scope of practice a little bit. I think it was a nice article to kind of just say that, these are easy kind of interventions that we can do that will potentially have big effects for people down the line.
Right. Okay, that sounds good. So we, any article we didn't do, I'll move to next week's Journal Club. I'm going to add a couple other articles. I just reviewed all the papers on IV Tylenol since Massachusetts just added IV Tylenol to paramedic units. So I'll add the paper that was in a few months ago in Academic Emergency Medicine. There's another paper that just came out on subdissociative doses pre-hospitally for ketamine and reviewed all the literature. And then a few more good articles pre-hospital setting. How many people do we have on, Mike? Do you have a number?
It's not accurate right now.
It's not accurate? Okay, that's fine.
It calculates after we.
Okay, and then so upcoming stuff, we are headed to Staten Island University Hospital to give a lecture. We're headed to Jacobi. We're headed to St. Barnabas in the Bronx. We are headed to 2 more places I won't mention yet who we just got invited to. Anything else to share with everybody? That's all I can think of. So we're going to post this shortly on the website. Thanks for joining us. If you want to get on our email, we're up to 11,000 people now. Just send me your email and we will add you. And we will post this on our website so you can watch it whenever you'd like to. All right, have a good week.